Okay, then we'll shift to the other speaker, Professor Leszek from Poland, and he's going to talk about type 2 diabetes, pathogenesis, and its clinical relevance. Sorry.
Thank you very much. After this broad introduction, making a point of how important diabetes and increasingly is, I would like to spend like half an hour talking to you on the challenge, on the pathogenesis of type 2 diabetes, the area which is very much changing. We learn more and more on that, and it is simply very much relevant to how we treat the most prevalent type of diabetes. I came from Poland, Bolanda. I work in Warsaw. I'm the head of diabetology internal medicine department at Warsaw Medical University, and that's the overview of our old city. Although it's not very old, Warsaw was 95% demolished during Second World War, so everything this is rather brand new, like as if you went to US, but I hope it looks nice. The shortest definition of diabetes, and that's one of the beauties of our favorite disease, is that as much as it is deadly and complex in terms of pathophysiology, the definition consists of only 2 words, really. If I want to explain anyone who's outside medical field what is diabetes, I say, well, this is the condition when your blood glucose level is chronically elevated. Of course, there are many reasons and many roads leading to this, and I will be talking about it, but just untangling this term, chronic hyperglycemia, is a major task for current researchers. So my talk is like in 3 parts, unequal in length. How does it start, this chronic hyperglycemia in type 2 diabetes? What happens after it starts? And as every good story, I should also tell you how does it end. So let's start with the beginning. What makes people hyperglycemic or type 2 diabetic? This is a picture I took in England in a waiting room of one of the endocrinology or diabetes outpatient services, and all these 4 people here, they have type 2 diabetes. But if you look at them, you see that there must be something different in each of them. The couple on left hand side are the elderly couple, and this type 2 diabetes results in them from probably different causes than the one of the most obese person here, this man in his mid-30s, but also the one on the right, who's relatively slim, also has type 2 diabetes. So it is a heterogeneous concept of type 2 diabetes, the big bag in which we put many patients having different clinical and pathophysiological features. On the other hand, that's another picture I took in Italy at a camping site. This is a family of friends having lunch together, and if I asked you who of these people have diabetes, well, you probably would say, well, everyone. Any of them could have, but actually only the man on the right in this blue t-shirt, he's got diabetes, and the other one who's sitting opposite to him, having probably a bigger belly, he does not have diabetes. So there must be something mysterious thing which makes them different in terms that one of them has high blood sugar, the other does not. So it mustn't be that simple, and indeed it is not. A very old concept of type 2 diabetes, still in a way valid, but this is only a small part of all pathophysiology, was known years ago. This is a picture from 1993, so many years ago, showing what happens really when we develop diabetes. And type 2 diabetes is the effect of coexistence, or the result of coexistence of 2 disorders, as we know: low insulin sensitivity and relative insulin deficiency. So if you look at these curves here, And if you look at a normal glucose tolerance curve, this is this continuous line in the middle, when we get older, we move on this x-axis to the left-hand side. We move from right to left. Our insulin resistance increases, or insulin sensitivity decreases, and as long as it is, there are many reasons for that. The one is just slow increase in weight, which occurs while we age. And when it is compensated with increased insulin secretion, then we're fine. We don't develop diabetes. We might be very obese, and there are people who are extremely obese. I could just show you at my department we are hospitalizing. We just last week the lady who's 170 kilograms of body weight. She's only 36 years of age. We will refer her to bariatric surgeons, but my younger colleagues were amazed that her blood glucose was absolutely normal. We did oral glucose tolerance test. It was absolutely normal, although she was like two men in one person with huge belly and a typical case of morbid obesity. But she produced so much insulin that she compensated her obesity. So when it happens, we're fine. People are obese, are insulin resistant, but do not develop type 2 diabetes. The moment this insulin secretion is not enough, you may fall in this blue area in this figure, which is impaired glucose tolerance, and if it is really low, this insulin resistant cannot be compensated and patients develop type 2 diabetes. And this traditional view on type 2 diabetes is still valid. We did not resign from that, but now we know much more what's behind hyperglycemia in type 2 diabetes. So sometime later, Ralph DeFronzo, an eminent researcher from San Antonio, Texas, one of the inventors of insulin resistance really, when he received his Bunting Award, Bunting Lecture, given him by the ADA, in 2008, in his lecture, he presented the view on the pathogenesis of type 2 diabetes, and first he showed this figure saying, oh, that's a very simplistic, simple, if not simplistic view of type 2 diabetes pathogenesis. Then we have the bottom two disorders, decreased glucose uptake and increased hepatic glucose productions, are clinical features of insulin resistance, and if they are associated with impaired insulin secretion, then the hyperglycemia occurs, and that's pretty simple to understand. But in the same lecture he also showed that nowadays we know much more, which I will show you also in a moment. But this simple view also makes a clear differentiation between type 1 and type 2 diabetes. Well, you would say, well, that's obvious, there are two different diseases. There are, but I will show you how they start to overlap, because we have problems with classifications in an increasing number of patients. But there is some clinically relevant difference, which is, and it's not about insulin deficiency really, which makes, in my view, type 1 and type 2 diabetes clearly different. Because both diseases are characterized by ineffective insulin secretion. In type 1, this is simply non-existing, because beta cells were damaged, and clinically there is no insulin secretion after a year or two since type 1 diabetes was diagnosed. In type 2 diabetes, insulin secretion is decreased, but it's always present. But the main difference, in my view, is rather in this insulin resistant compound, because in type 1 diabetes, insulin action is basically unchanged as long as the patient is not obese, while in type 2 diabetes it will always be decreased. So that makes this treatment in type 2 diabetes especially difficult. In type 1 diabetes, once we start giving insulin, the effective treatment is about educating the patient and adjusting the doses to daily life. While in type 2 diabetes, when insulin doesn't work or works very inefficiently, then this is a major challenge. So that's one piece of pathophysiology which is very closely related to the treatment of type 2 diabetes. But as I said, now we know the picture is much more complex. That's a more thorough view on type 2 diabetes pathogenesis. So hyperglycemia, apart from this decreased muscle uptake of glucose and increased hepatic glucose production, if we start from the top, we also have decreased incretin effect, which eventually was translated or is being translated into new treatments. Another feature of insulin resistance is increased lipolysis. So there is a lot of free fatty acids in the bloodstream of our patients, and free fatty acids are direct competitors with glucose as energy substrates. Kidneys uptake more glucose from the primary urine in patients with diabetes. There is a dysfunction in the brain with all the appetite regulation. Also, the overactivity of alpha cells and high levels of glucagon are often present in type 2 diabetes. So it's at this point, and this was almost 10 years ago, we already saw that these pathways leading to hyperglycemia are not just one or two, but I think you can count up to 8 arrows here. But that's, again, it was almost 10 years ago, and last year we have another step forward in understanding of type 2 diabetes. The group of experienced diabetologists and researchers, one of them were the presidents like James Gavin, the presidents of the ADA. They published an article which aim was to provoke all of us to think, and they titled it "The Time is Right for a New Classification System of Diabetes," and it should be based on beta cells. It should be a beta cell-centric classification scheme. So what they argued is that, as I already said, we see an overlap of various features basically between type 1 and type 2 diabetes. We see patients who have all the features of type 2 diabetes, which is shown more on the bottom. So they are rather older, they are obese, they present something which we used to call metabolic syndrome. They have high C-peptide, higher than average sometimes. Insulin production, also subclinical inflammation could be easily found in them. And we have type 1 patients with all the autoimmune reactions, T-cell activations, autoantibodies present and requiring insulin treatment. But there is a whole area, the gray area you may call it, in between, where there are patients who are obese but have autoimmune reactivity detected, and the other way around, like the one on the right in this picture from England I show you. Patients who are relatively non-obese but also are just slightly overweight and they have diabetes already. So we are using a very simple view to diagnose our patients, but now we know that the times are about, this is my feeling, it's just my personal view, but the times are about to change, and in the next, not a year perhaps, but maybe in 5 years, we'll see maybe not the change in terms we'll be using different terms, but these classifications will have much more subtypes than we have now. And just to show you the evidence, this is the study from the Bahrain, so that's the study from Arab ethnicity from the Gulf region. A very interesting one, because the colleagues there took very young people at the age below 20, and they measured two things. They measured all of them had diabetes. The group was not that small as for young people. It was close to 300 patients. And they measured autoantibodies and they measured insulin secretion. And if you look at on the left-hand side, on the left bar here, the group 1, this is typical type 1 patients. They have autoantibodies and they have no or little insulin secretion. This is shown here as AB plus and beta minus. On the right-hand side, there is a group 4, which is classic type 2 diabetes with beta cell functioning, insulin production maintained, and absence of antibodies. But there are two groups of patients in the middle, and the group 2 are patients who also have no insulin secretion, beta minus, but no autoantibodies are detected. This was the smallest group. And the other group, which we call double diabetes, patients with preserved insulin secretion but present autoantibodies, and they are all below the age of 20. So it's not that you will have in adolescents or in children you will have only type 1 diabetes. Majority of this group studied in the Gulf region had classical type 2 diabetes, although they are all below the age of 20. And the final element, just to make the picture more complex and, as Professor Boulton said, to confuse you but at a higher level, comes from the most recent annual meeting of the EASD in Lisbon, where the group led by Leif Group, it's a very much experienced geneticist and researcher in diabetes from Scandinavia. And it is kind of a discovery they presented there, is they suggested that the patients with what we call type 2 diabetes could be grouped in several groups, and the differences also in clinical course of their diabetes is very clear. So what they did is they took 15,000 newly diagnosed diabetes patients and they measured 6 variables, pretty simple: age, BMI, HbA1c, HOMA insulin resistant index and HOMA beta cell function index, insulin secretion, and GADA autoantibodies, which are typical for type 1 diabetes, of course. And they measured the disease progression, they assessed the treatment and development of complications within 4 to 5 years, so it wasn't a very long-term follow-up study. So what they found out is that you can classify people which are which have diabetes into 5 groups, and I hope you can read what is in the table here. But the upper line says severe autoimmune diabetes. There are 6.5% of these patients classical type 1. But all 4 other groups are people we would call type 2 diabetes, and you can see their differences, because what they called was, they found types or patients who would fulfill the characteristic of severe insulin deficient diabetes. These patients had higher HbA1c, they quickly required insulin, and had more frequently retinopathy. They also found severe insulin resistant diabetes, and these patients were at higher risk of kidney disease, not retinopathy. So whether you are insulin resistant or not affects your complication risks, apparently. The next group was mild obese diabetes, patients who had only modest metabolic disorders, and mild age-related diabetes, and this was the largest group, 40%, with also metabolic mild disorders. And that I could show you the patients of mine or whom we see at our department who could be put in each of these categories, because if diabetes is diagnosed in someone who is 78 years old, that would be a mild age-related diabetes. But they do not only look at clinical features, they also assess the presence of gene mutations, these 2 columns on the right, most frequently found in type 2 diabetes, especially TSF7L2, and this particular mutation. And this was present in 3 of these groups, while the other was present only in 2 of these groups. So we are, I think, at the brink of thinking, okay, there are different clinical phenotypes of diabetes. Those who are more likely to need insulin are more likely to develop retinopathy, those with more insulin resistant and prone to nephropathy, and so on and so on. So I don't want to confuse you, as I said, too much, but just saying type 2 diabetes is insulin resistance associated with beta cell dysfunction, it is still true, but it's only part of the true, and it's very much imperfect. In the same article I just showed you from last year, the authors also said, proposing this change of the classification, that they counted the pathways which lead to hyperglycemia up to the number of 11. And the one which are on the right, at the bottom on the right hand side, The three are typical for insulin resistance, so it's increased glucose production, decreased peripheral muscle uptake, and increased lipolysis. But there is also the brain, which takes part in developing hyperglycemia. We know also that bacteria in the gut, here on the left-hand side at the top, are important. We start to acknowledge more and more the role of subclinical inflammation, the stomach and the gastrointestinal tract role, where also patients experience higher glucose uptake like in the kidneys. But the central part of this picture says that the final common denominator, which is present in all type 2 diabetes patients, is lack of insulin. It's either lack of its function, or it's either lack of a hormone itself, and it might be due to beta cell mass, decreased beta cell mass, or decreased insulin secretion. So we would call it again beta cell dysfunction. In a way, somewhere close to here, we have defects in incretin effect and increased glucagon levels. So to treat this must be a real challenge, also must be fascinating from intellectual point of view. And in the same paper you will find the figure we've added the drugs. All those names in blue are the agents which we might use to counteract each of these pathways. Some of these drugs are not available in Europe, only in US. Some of them are not available, or minority of these drugs are available in many countries globally. But in theory, at least, we can combat each of these pathways. So it is a fascinating time for treating type 2 diabetes, although becoming more and more expensive for many of our patients. And just to add one more piece to the story of how hyperglycemia starts, I would like to draw your attention to the concept of maturity onset diabetes of the young, MODY, so-called MODY. That's a genetically determined diabetes. I must say, when I was preparing this lecture, I was looking through the literature, looking for some MODY, some papers or studies on MODY diabetes prevalence in Egypt or in Arab population, and I couldn't find any, I must say. But you must have patients like this, I'm pretty much sure, because it's we all humans, and we didn't have these patients in Poland either 15 years ago, but when we started to look for them, we found them. MODY is a diabetes which is caused by a single mutation in a gene which causes, for example, that insulin is not effective enough. It doesn't have to be treated with insulin, could be treated with sulfonylurea. Some of these types are not treated at all. Now we have more than 15 types of MODY, but these through MODY 1, 2, and 3 are most popular one. We slowly start calling them MODY. We call them glucokinase MODY or glucokinase disease, HNF1 alpha or 1A, and HNF4A or 4 alpha. Those HNF are hepatic nuclear factors that are responsible for insulin action on the liver, on hepatocytes. And there's also a number of genetically determined diabetes found in neonates, neonatal diabetes. If you've ever had a patient who developed diabetes before the age of 6 months, so in very early infancy, this must be the case of this neonatal diabetes, and these patients don't have to be treated with insulin. Sulfonylurea usually helps. And just to show you that they are not just researchers' invention, that's one of the recent study analyzing various populations, mostly in Europe, which checked the prevalence in a large cohorts of patients suspected of having MODY. The typical patients for MODY, you may suspect it when it looks like type 2, it's not severe, glucose is mildly elevated, and the patient is in their 20s or 30s, is slim or just slightly overweight, and very typically diabetes was present on one side of his or her family. So everyone on parental side or maternal side has diabetes, then you should be suspecting MODY diabetes. But if you look at prevalence, MODY 1 is not actually the most frequent. It's MODY 3 in northern populations in Europe, including my country. It's MODY 3 which we found more often now, and like in UK, but MODY 2 in moving more south. So perhaps this is the area where you could look for your patients. It needs genetic studies. 10 years ago they were very expensive. Now at my department we can check for one MODY for the cost of about 150 euro, so that's not that expensive, and we tend to find them more and more. Once you start looking for some diseases, you will find it. And it's crucial for the patients because it determines the treatment, and it also determines their prognosis, which is basically quite favorable. Very few MODY patients develop severe complications. And if you're unsure, you can, if a patient might have a MODY or not, you can use this web page, www.diabetesgenes.org, MODY probability calculator. The only problem is it has been prepared from the data from European cohort, and I'm not sure how much it applies to your patients, but it cannot be that different. You put the age, and I entered some data here, like the age at diagnosis of 26, a woman treated with oral agents or insulin, but not on insulin, just with oral agents, with BMI 29 and HbA1c 6.7. Now she has 35. Sorry, she was diagnosed when she was 26. That's a real patient, which eventually came out to be MODY, and had parents, at least one parent, affected with diabetes, and the bottom line says that based on these features the patient has a 58% chance of having MODY. So it's 1 in 1.7. So 1 out of 2 patients like that will have MODY. So you can use this just to assess the risk and then think where I could perform the genetic studies. So what happens after? Because I'm talking about pathophysiology and its clinical relevance. So once we have a patient with hyperglycemia and we decide he or she is a type 2 patient, type 2 diabetes patient, what happens after? Then it only progresses. Professor Bolton already mentioned UKPDS. This is our canonical study, which really learned us a lot, and it defined our still current thinking, although it was published 20 years ago, about type 2 diabetes. What this study found out, and it wouldn't be possible today because it would be unethical, but at that time no one really knew what to expect. The organizers or the authors of this study, Robert Turner, the late Robert Turner, now the group is still led by Professor Uli Holman at Oxford, took 5,102. This was the final number of enrolled patients into United Kingdom prospective diabetes study since the diabetes diagnosis, and they followed them for average 10.5 years. And what they found out is that regardless of the treatment used, the patients were randomized to conventional treatment, which today's would mean almost no treatment, just diet and exercise, non-pharmacological one, or insulin, or to older sulfonylureas or metformin. And one of the major discovery of this study was that regardless of the treatment used, the glucose control only deteriorated. It improved a little at the very beginning in the first year, and then it deteriorated. So once we don't treat patients like that anymore, but if we kept a patient on a single agent, his blood glucose or her blood glucose would only get worse. And what I personally find fascinating is that the angle these all curves are going upwards is basically the same. So we can hardly affect beta cell function with one agent only. Why beta cell function? I was privileged over 10 years ago to spend a few months at Oxford at UKPDS place. This is as close as I was allowed to approach UKPDS patients' data, patients' charts. This is the archives where all 5,102 patients' charts are kept. They didn't let me take out any of them and to read them. They told me that if I saw how the data were reported, I would never believe in anything from UKPDS study. So, but at least I could see them and took this picture. And I was added to the group which analyzed the change in insulin resistance and insulin secretion over the years. And as you can easily see in this figure, insulin sensitivity, as much as it was lowered since the beginning, about 50 to 60% of normal, it was more or less stable during the course of the disease. So patients had half of the typical insulin sensitivity, but this was not this element of type 2 diabetes which was responsible for the disease progression. What was responsible was failing beta cell, which improved quite remarkably by 50% when the patients received sulfonylurea. This is this red curve, but then after a year it started to go down again. So this progressive character of type 2 diabetes is also the result of pathophysiology. Beta cells are working less and less effective, and that's why it all translates to increased treatment. But there are also some more hard data on it. This is the figure. I hope you could see the differences between left-hand side and right-hand side pictures. These are all beta cells, or rather Langerhans islets. The pictures on the left-hand side are normal islets. I took it from various papers or books. Then, when diabetes develops, if you look at the top, you have hyperplasia of islets. The islets somehow multiply with smaller size of islets, but because of we believe that this is the way it happens, because of the increasing demand on insulin and the metabolic stress which is put on beta cells and islets in general, they degenerate, and the islets on the right hand side have many fewer cells but have a lot of this pinkish compound which is amyloid, and this is why the patients do need insulin at some stage or need some insulin secretion stimulation. The shortest route is from the one which is put in this circle in the middle. You have a healthy islet at the top, and after 25 years, because the specimen at the bottom, the sample was taken from the patient who died after 25 years of type 2 diabetes, very few cells and plenty of amyloid. So we also have this sort of example showing us what happens after hyperglycemia starts. And as I said, it translates into this multiple treatment, but at the very end, at the bottom of this algorithm, we always end up with insulin therapy. I guess we'll be seeing this picture many times during this course. And just briefly at the end, how does this end? Well, it ends with complications, which also makes the treatment of our disease a challenge, because we do not really treat to keep glucose at the normal level. We keep the glucose to prevent the arteries of our patients looking like that. The picture on the left-hand side is a perfectly healthy endothelium. That's a digitally enhanced picture of a healthy vessel. And the one on the right is an aorta of the patient who lived with type 2 diabetes for almost 30 years. And you can see that the wall is severely damaged, and if you heard the noise of the scissors cutting this aorta, you would just hear how it goes through the calcium deposits and how it cracks and how it's difficult to cut this stiff vessel through. So we want to prevent it. So it's not just a treatment just for glucose, it's all about saving vasculature, and we will discuss it in details during these 3 days. So finally, I usually end this talk showing that picture just to make a case for type 2 diabetes. This was published over 15 years ago in a journal for British practitioners. This is a picture of a couple, married couple, they both have diabetes. The picture was taken in Edinburgh in Scotland in a hospital. And the patient who is hospitalized is this man on the left. And you don't have to be very conspicuous in clinical observation to notice a slight asymmetry of his face. He already had a stroke. He was admitted because of the foot ulcer. He also has a kidney failure. He's only 63, as is his wife. And for years he was told that he doesn't have, well, this diabetes is not that serious, just mild touch of sugar. And he died 3 months after this picture was taken. His wife, also of 63 years of age, also has diabetes, but she's got type 1 diabetes since the age of 8. She took tens of thousands of insulin injections. Her only complication is mild retinopathy, and other than that, she's basically okay. So if you think that type 1 diabetes is a serious diabetes and type 2 is just because people are obese and eat too much and they have slightly sugar elevation, that's not true. Even mild glucose elevation is very damaging to the vessels. So this is how it ends, and this is what we want to prevent. So just to conclude, rules for diabetes diagnosis, I didn't mention them, but they are very simple, well defined, and easy to follow. It's not a challenge to diagnose a diabetes, basically. If the glucose crosses certain thresholds, we say, okay, hey, you have diabetes and you need the treatment. But the current classification is far imperfect. It's only based on crude clinical features, mostly absolute versus relative insulin deficiency. And as much as this insulin is needed, with more and more therapies, we are actually able to delay insulin treatment. This rapidly increasing knowledge on glucose metabolism regulation pathways and on genetic traits shows many new or just being acknowledged subtypes of diabetes, and they are difficult today to be easily differentiated, but the tools are coming, and I hope we will be much more able to decide whether the patient needs this or that treatment. This complex pathophysiology therefore makes the choice of treatment difficult, but the two things may be certain: that autoimmune diabetes of course requires insulin therapy, no doubt about it, while non-autoimmune diabetes, whatever type or subtype it would be, may be effectively treated first with lifestyle changes, as we know, but also with increasing number of non-insulin agents, while insulin therapy as needed, because we do not want it, we don't have to escape from it, it actually will be using, and this nowadays we see it being used at an increasingly later stages of the disease, although paradoxically still in many patients we initiate insulin therapy too late, and we will also discuss it during the workshops and lectures during this course. Thank you very much for your attention.
Thank you, Professor Leszek, for this difficult simplicity or simple difficulty lecture. Anyone would you ask a question? Yes, please, go ahead.
Can we have a microphone there?
I would like to ask if there is any future intention to classify diabetes age-related as hypertension. Why diabetes also didn't classify it as that?
That's a very good point. That's a question I ask myself very often, because the strongest risk factor for diabetes is age. In my country, we have good data about it. A quarter of people over 60, and Poland is in the center of Europe, and our society is aging, unlike yours. You're a very young society. But in my country, a quarter, 25% of people over 60 have diabetes. Half of those over 80 have diabetes. But we think, well, at least I think, is it then really so abnormal to have slightly higher glucose when you're 75 or 80? It is definitely not that harmful, because people will not live as long as they would have diabetes when they are 40. But that's a major challenge, if we decided to say, okay, diabetes when you're over 60 or 70 should be diagnosed at a higher levels of glucose. We would need good studies, and also You must be seeing patients like that. We see ladies, they're mostly ladies, men live shorter, but ladies who are 82 and they are as young biologically as other ladies who are like 65, and the other way around. We see people in their 60s who are biologically much more advanced. It's a difficult issue, but I also have doubts whether we are not over-diagnosing diabetes in people who are old. We are definitely over-treating diabetes in people over 80s. We see it more and more often in Europe, and if you come to annual meeting of the EASD, there are lectures nowadays, what should we do not to over-treat people who are in a very much advanced age. But that's the good point. But as you may feel, the tendency is the other way around. Just 2 or 3 days ago, Americans decided to lower the threshold for hypertension diagnosis. I will be talking about it in my lecture tomorrow. So we're not moving up with the thresholds, we're only lowering them down. So what we discussed this, but what we'd rather see is that pre-diabetes will disappear, and what is pre-diabetes will be called diabetes, and we will diagnose it when anyone has 100 milligrams of deciliter of glucose.
Any more questions? Yes, please.
Yeah, there's a
Take
there's a
just
question
2
there.
questions. Yes.
Before treating diabetic patients, are we need to investigate diabetic patients to know pathogenesis of the disease and targeting them to targeting the pathogenesis?
That would be a very good thing if we could, for example, decide from the very beginning how much, what's the whatever the phenotype or genotype of the patient is, or how much he is or she is insulin resistant or insulin deficient. The problem is that it's kind of difficult, also expensive. Some of my colleagues, for example, when they are not sure, when they have young people diagnosed with, let's say, they think, oh, it's a type 2 diabetes. But someone is not very much obese, let's check what is his or her C-peptide. But if you measure only fasting C-peptide, it doesn't tell you anything. Even people with type 1 diabetes for 5 years duration might have still detectable C-peptide. So to fully assess insulin secretion ability or reserve, you would have to make a glucose test to assess C-peptide or insulin secretion. So then it's become complicated. Much simpler is, especially if you have limited treatment options, if you can only afford, or if your patients can only afford metformin, sulfonylurea or insulin, and all new drugs are expensive, the simpler way is just to give a drug and see if it works or not. And that's what we do in clinical practice. But it's rather the choice, the negative choice, I would say, is we do it because it's the simplest way and the cheapest. But it would be much better if we could look a little bit more deeper into the pathophysiology of the disease. And I think it will happen, not today, not next year, but in the next decade, perhaps so, yeah.
Last question over there.
Definitely the MODY diabetes needs diagnosis, that I would say. If you suspect MODY, that should be screened or diagnosed genetically. Okay?
You discussed MODY.
Oh, please stand up, please.
Sorry.
You discussed MODY, 5 types, I know. Now there is MODY.
I can't hear your question.
You discussed MODY. Some of MODY types
Okay.
well controlled by sulfonylurea, other by insulin. Okay.
If someone is well controlled with sulfonylurea,
Yeah, but clinically, when you have a patient, for example, you have low resource setting, you know, we cannot identify genetically what happened in this patient. We have to treat him, okay? But how you can we can treat him? You know, some patient no need for treatment, some need.
Yeah, well, the answer is in your question. If a patient is treated with sulfonylurea, is well controlled, we stick to sulfonylurea. If it's not, we move to insulin. It's what now we are seeing. What I wanted to say is just we see the increasing gap between our knowledge in pathophysiology of what we call type 2 diabetes, and despite we having more and more agents, we choose them only due to efficacy or to hypoglycemia risk and the costs, of course. But we would have to bind it together somehow. For example, decide, yes, in this patient, incretin-based therapies would work best. But at present, if sulfonylurea works, you stick to it. If they stop, we move very often to insulin, because in many countries, this is the cheapest option. Insulin is usually quite well reimbursed by the governments.
Okay. To make it easier, you can write your question in
But
a paper.
we will also have workshops on type 2 diabetes treatment options on Saturday, I think, and I will be happy to answer all your questions or to discuss it.
I'll ask to comment.
Yeah.
Do you dislike the term monogenic diabetes?
Do I?
Dislike the term the monogenic diabetes for Modi?
Do I dislike?
You dislike monogenic diabetes, the term monogenic
The
diabetes.
term. I have not such strong feelings about the terms about monogenic. It's a traditional term. The geneticists simply said that MODY is an old-fashioned term because it doesn't only affect. It's an old term which develops into, as I said, maturity onset diabetes of the young. But we often diagnose it in people who are in their 40s because nowadays we have the tools. So this is a kind of obsolete term, traditional one. Like if you remember IDDM or NIDDM diabetes. So this was dropped because many doctors who were not diabetologists called every patient treated with insulin, also type 2 diabetes treated with insulin, like insulin dependent, and we understood IDDM as type 1. So I guess we will have a better name because saying GSK MODY or HNF1A MODY is more complicated. Interestingly, more and more those mutations are being discovered. So I guess the new classification will arrive here as well.
Now, Professor Ines Shaltut. Thank you, Professor Leszek.
Thank you very much, and I will be happy to answer any questions, as I said, during workshops or simply during the break. Thank you.